Fine.
I'm just trying to get into my... good afternoon to you all and a warm welcome for myself into Dhaka. I never miss a chance to be in Dhaka for two reasons. One is hospitality of people and second is hilsha cooked in mustard oil. So my 25 minutes will start now. Overview of cardiomyopathy. We know that there are three types of cardiomyopathies: restrictive, hypertrophic, and dilated. Each type of this cardiomyopathy is a book in itself. And people have spent their lifetimes in subsets of these books and chapters. I can finish my talk here with this slide, but I would prefer to start my talk from here. So there are this cartoon is sum and substance of what I'm going to talk. This is on the top left is normal. On the top right is dilated cardiomyopathy, where the ventricles are dilated and they are poorly functional. This on the left is hypertrophic cardiomyopathy, which means the walls of the ventricles are thickened but have become stiffened. And this fourth variety is restrictive cardiomyopathy. The walls of the ventricles become stiff, but they may not necessarily be thickened. Now, I'll start with the hypertrophic cardiomyopathy and the mimickers. So here is an example of hypertrophic cardiomyopathy where there is a premature closure in M mode. And when M mode was the only modality of diagnosis and echocardiography, this used to be the sine qua non, premature closure. That means there is an obstruction in the LVOT, which once the gradients fall, opens up again. And this is a dip, which you see in the conventional box type. If you see that there is a premature closure of aortic valve, start thinking in terms of LVOT obstruction. And any LVOT obstruction on those days was taken to be hypertrophic obstructive cardiomyopathy. Now, not only that, you can see a classical kind of dagger shape of Doppler parameters. And when you look at hypertrophic cardiomyopathy in its true sense in the conventional 2D or M mode in 2D, you find that here it is that there is a thickened cardiomyopathy interventricular septum. It is asymmetrical. The thickness of the septum is far larger than the posterior wall. Now you don't call it posterior wall, you call it inferior lateral wall. And here, when you look at it, you will find that there is a asymmetrical septal hypertrophy too. Now, there are several types of hypertrophy. We are just going to skip through most of them, but to complete that not all hypertrophies are hypertrophic obstructive cardiomyopathy, or not all hypertrophies are hypertrophic cardiomyopathy. Again, the most classical example we see is in hypertension. And when you see it in hypertension, you don't find the characteristic changes as you would expect in some infiltrative disorders. And the myocardium is not very classical. It is the usual myocardium. And here it is that you will find that many a times with hypertrophy of any variety, you can get an LVOT obstruction. Here, there is some gradient and turbulence across the LVOT, as you can see in the color Doppler, but this is not classical hypertrophic obstructive cardiomyopathy because you have to have these things in absence of hypertension. Here is yet another way in which you can find hypertrophs. This is a very densely calcific aortic valve, and when you see the Dopplers across this, you'll find that there is a aortic regurgitation, no doubt about it, but the Doppler patterns are quite classical for severe aortic stenosis, and this is what it is. So there is some bit of an AR also, but by the Doppler tracings, the AR doesn't seem to be too severe. Actually, longer the pressure half time in aortic regurgitation, lesser is the severity of aortic regurgitation. Now, this is a place where on the left, if you closely look at the tip of the mitral, you'll find that in systole, there is a systolic anterior motion. This goes towards the septum. And here, when you see the short axis, you'll find that there is classical hypertrophy, which is there, and it is quite concentric in nature rather than asymmetrical septal hypertrophy. It's not that you will have only asymmetrical septal hypertrophy, but if you get a concentric hypertrophy, start thinking in terms of several other things other than hypertrophic cardiomyopathy as a possibility. Now, this is what we find. And if you look at it, infiltrative disorders will have this central corridor sign. This is a very important sign to see. If an amyloid is there, the central hypertrophic cardiomyopathy, this is an infiltrative disorder, and that's the reason why you must think in terms of something else other than hypertrophic cardiomyopathy. And this is classical amyloid as what is expected in several features. It has a sparkling feature. If you look at the myocardium, it has a characteristic sparkling feature. And when you do a strain, then the bullseye will have an apical sparing. Though apical sparing is not necessarily definitively because of amyloid, neither is it a definitive thing against amyloid. But once you start seeing a cherry on top kind of a feature, then amyloid becomes high on the probability. Now, this was proven by biopsy. We took it from the myocardium. Now, this is another. So most people would say this is amyloid. But amyloid, if you look at this in different views, you'll find that there are certain serrations, there are recesses. Amyloid is solid, should be solid. I mean, not necessarily so. And this is the reason why we started investigating this further. Because classically speaking, if you make a diagnosis of amyloid, there are treatments available for it now, at least in 2020 onwards. But here, if you look at this, this was not classical amyloid, because if you see amyloid, you should not see these recesses, and somehow the things were not gelling. And when we started digging at it too much, then we found that yes, we got an MRI done, which was kind of non-contributory, and we went ahead with a biopsy. And once we got the biopsy done, we found, he had a mitral regurgitation too. So this again is a restrictive cardiomyopathy kind of situation. And our diagnosis turned out to be infiltrative disorder, which was Fabry's disease. So not all restrictive disorders will be amyloid, not all restrictive disorders. So one more example of RCMP, which is very peculiar to this part of the world. Now, if you look at this, you'll find that the apices are obliterated. The left ventricular apices apex is obliterated. So we find this in eosinophilic hyper eosinophilic syndromes, but here the eosinophil counts were normal, and then we found that this turned out to be nothing but endomyocardial fibrosis, which is quite peculiar to south of India, as we see. So how do you make a diagnosis or a suspicion of restrictive cardiomyopathy? The first suspicion of restrictive cardiomyopathy is if you have biatrial enlargement with small ventricles. If you have biatrial enlargement with small ventricles, rest assured what you are dealing with is probably a restrictive cardiomyopathy situation. Just to complete the restriction versus constriction, this is always a fight. And if you look at the Doppler parameters, it will all be same. But if you have a restrictive cardiomyopathy, you will not get a septal bounce. Actually, septal bounce, if it is seen in only 2-3 conditions. One is in interventricular conduction defect, left bundle branch block. Normal variation is yes, but if you have a suspicion of anything, restriction versus constriction, if you get a septal bounce, 91% of the times it will be constrictive pericarditis. Now, this is a very classical constrictive pericarditis, and if you look at this, there are classical inspiratory. The moment there is an inspiration, you'll find that the septum bounces backwards and it pushes into this is a very, very gross example, not that you'll find it very often, but once you know the gross examples, you'll be able to see subtle things in future. Now, again, the Doppler velocities are quite classical. If you see a drop of Doppler gradients by 25% on the left side and more than 40% on the right side, they are quite classical for constrictive pericarditis. Not only that, you have to document RA pressures being high, which is very easily done by seeing dilated IVC. Now, these are few differences between restriction and constriction. If you see a pericardium which has got a calcium, favors constriction. If the LV size is normal, it is constriction. However, if there is hypertrophied LV, then it favors restriction. Regional wall motion abnormality may be seen in restriction. Echogenicity is characteristic few in restrictive cardiomyopathy, like in amyloid. Endomyocardium may be thickened. Global LV functions are by and large normal in constriction, but in restriction they may be impaired. Atrial size is by and large, biatrial enlargement is a feature of restrictive cardiomyopathy. LV filling absent respiratory variations is seen in restriction. However, if there is a fall in inspiration, it favors constriction. Fall of inspiration and during inspiration, if there is an increase in right-sided valves like tricuspid, it favors constriction. Now, what is important is the lateral versus medial tissue Doppler. Now, what happens in constrictive pericarditis is that when the heart is relaxing, it relaxes, and then there is a sudden caging. This sudden caging occurs because of a thickened pericardium. So when it relaxes, there is a sudden caging. So where is the caging? Anteriorly, there is pericardium, it cages. Laterally, there is pericardium, it cages. Inferiorly, there is a pericardium which cages. Posteriorly, there is pericardium which cages. The only place where it cannot cage the pericardium is the interventricular septum. So this interventricular septum starts bouncing. So you see a septal bounce. So there is a tissue Doppler. Normally what happens if you see the tissue Dopplers of medial versus lateral, you'll always find that the lateral tissue Doppler is lower than the medial. Lateral is more than the medial. But here what will happen is that because of the caging effect of the pericardium, the lateral tissue Dopplers are truncated and medial becomes higher. This is a reverse. This is a reverse phenomena, and this favors constriction. So this is easy way to find out restriction. You see, what happens in constriction is that the initial phase of diastole is unhampered. So the tissue velocities are fairly well preserved in constriction, except once there is a caging effect because of the pericardium. However, in restriction, the primary pathology is that of myocardium. And in myocardium, the problem of diastole is from the word go. So initial diastole is also involved as again constriction, where the initial diastole is not hampered. Now there is yet another cardiomyopathy where the heart is weak and the ventricles are also enlarged. This is classically dilated cardiomyopathy. The dilated cardiomyopathy by definition is a cardiomyopathy where there is global hypokinesia. And many times you will find that this is more of a myth than reality, whereas global hypokinesia can be a part of ischemic cardiomyopathy, and regional wall motion abnormality is seen in large percentage of patients with dilated cardiomyopathy. And to sort out this issue, many a times you will need to use your other modalities like dobutamine stress echo to sort it out or make it surface. So these are the DCMP myths in reality. 40% of dilated cardiomyopathy have a wall motion abnormality, and not all cardiomyopathies are irreversible. We also feel that many a times that if you have dilated cardiomyopathy, it is irreversible. This is a phenomena which we have recently started resurfacing, though the autopsies have shown a spongy myocardium several centuries back. But here is an example where there is a non-compaction which will lead to a dilated cardiomyopathy. Not all will do that, but there is a small percentage of non-compacted LVs which eventually will end up with dilated cardiomyopathy-like situation. And this is how you diagnose. So if you look at the ECG on the left side, actually the ECG on the left side is LVH with strain. But when you look at the echo pictures, you find that the LV is poorly functional. Not only that, there is global hypokinesia too. And when you see it in other views, so this patient had a clot also at the apex, other than it having a spongy myocardium or a non-compacted LV. Now, this non-compacted LV is diagnostic in two ways. One is that you have to see the recesses in which you can see the entry of the blood. And for this, you have to get the Nyquist limits down. And number two is you have to see the ratio of compacted versus non-compacted. Of course, if you see the tissue Dopplers are slow and low. And the pattern is kind of tall E, small a, and restrictive cardiomyopathy once it has reached that stage of advanced heart failure stage. So these are a few examples of non-compaction, which unfortunately has a variable. It's so unpredictable that you can't really say that which non-compacted LVs will end up with severe heart failure and which are the ones which will not. But here are a few examples that you would be able to see very gross findings. And the LV non-compaction occurs more often than not on the lateral side first, then rest of the places. So the diagnostic suggestions for non-compaction of LV is first and foremost is if there is a ECG and echo dichotomy. ECG shows LVH and this thing shows poor LV. This is as against amyloid. In amyloid, the ventricles will be hypertrophied, but the ECG will show small. So this is a dichotomy in which you can settle the issue several times. So more than 3 recesses, and to make the blood flow into the recesses, you come down on your Nyquist limits to maybe 27 or 25, and non-compacted to compacted myocardium ratio should be more than 2:1. Yet another cardiomyopathy, again, not a very recent discovery, but it was the first paper was published in 1990, where in Japan they found there were 5 patients who came out with something known as a stress cardiomyopathy. And how do you make a diagnosis of stress cardiomyopathy is that the wall motion, apex starts ballooning, and the bases, they are hypercontractile. Now, this hypercontractile LV at the bases is a typical feature of catecholamine-induced stress cardiomyopathy. Happens 9:1 time compared to men. Women are more prone to it. That's the precipitating factors could be physical stress like sepsis, surgery, parturition, and non-physical could be emotional upsurges. How do you make a diagnosis? You make a diagnosis of basal hypercontractility. If you look at this, this is a basal hypercontractile and the apex is balloon. Though more and more different types of Takasugos or stress-induced cardiomyopathy have been discovered, but the catch point is that you have to document normal coronaries. This is our one more example in pediatric of a dilated cardiomyopathy, 45 days old neonate, diagnosed to have dilated cardiomyopathy, was admitted for intravenous immunoglobulin therapy, and on way had generalized convulsion. Now, this was his ECG, by and large non-contributory, except that there were some QT interval which was prolonged. QT was rather markedly prolonged in this case, corrected for the age. I mean, if you look at the T waves are falling far beyond the middle of RR interval. So we know that QT interval is rather prolonged. Did the echo? Echo was global hypokinesia. So whenever you see a pediatric age group with global hypokinesia and poor LV, you start looking at Al-Kappa, you start looking at coarctation, you start looking at of the LVOT obstruction. We couldn't find any and we just felt that we must. So the familial history was that mother was not on calcium or magnesium, and ALPs were very high. Rest of the things was fine, and he turned out to have a very low calcium. And to manage this baby, we gave him injectable vitamin D, calcium, and magnesium sulfate, along with decongestive therapy with digoxin, Lasix, and ACE inhibitors. So there is a fight. If the blood pressure is fairly good, you must give alpha and beta blockers also. But in case the blood pressure is low, then you have to play with inotropes. Now, soon after that, this was, when was this? This was June and August. This is his echo. And you'd find that because so soon after correction, the LV starts improving, and it starts improving in not weeks or months, it starts improving in days. And this is after 3 months where the LV was fairly good. So this is one feature where in a neonate or a pediatric population, never miss a hypocalcemia. I'm not going into the mode of action, but I'll leave you with this and leave things for discussion more than anything else, that calcium has a mode of action which is direct myocardial contraction, increased digoxin effect, increased natriuresis, and direct effect on vitamin D on myocardium. Now, yet another example of a macroglossia with shortness of breath. Now, if you look at this, this is a classical amyloid. Sparkling feature in the septum, per LV, and there is nothing that you would want to see more. Again, here also there is a central corridor sign. Again, because any infiltrative disorder, and amyloidosis being one of them, is a classical example. I think I'm overshooting my time. I'll just stop here, and I'll be happy to take any questions in case there are any.